Hi, everyone. Today we have very special guest. It's Dr. Pierre Curie. He is a pioneer and national expert in pulmonary medicine and critical care, and also he's a president and chief medical officer of FLCC. And I'm sure many of you have heard about it, which focuses on the prophylaxis and treatment of COVID-19. And also, Dr. Corey became very famous when he went to the U.S. Senate in order to convince them to approve ivermectin for treatment. Last year, I did an interview also with Dr. Paul regarding the use of ivermectin in the treatment and prophylaxis of COVID. And since then, I don't understand it. For some reason, we don't hear about the drug. It hasn't been tried in one of these like big trials like Solidarity or Recovery. So what is going on? So today, please, if you give us like a brief information, why ivermectin is important to be used in treatment and prophylaxis. Is it good for like long haulers, for example? And also, if we already have very strong evidence which support the use of ivermectin, why do you think, the WHO or FDA or any of this like big organizations are not taking this into consideration? So yeah, please.
So the first part is easier to answer, which is, does it work? And it should come as no surprise, but my opinion, as well as my group's opinion, and we are very experienced physicians. We've been writing papers and studying interventions for decades. Dr. Marek, who you interviewed before, and Dr. Verona and Umberto Meduri, we have almost 1,500, 2,000 peer-reviewed publications. So yes. We're no stranger to assessing the evidence. And I will say that all of us are very impressed with all of the trials data. And the trials data keeps growing and getting stronger and getting stronger. And so right now we have at least 7, quite a few of them are large trials showing that it prevents the development of COVID-19. If you take it and you get exposed, your chances of getting sick are extremely low compared to if you're not on it. And that's been shown repeatedly in every trial that's looked at it. There's been no negative trials, not one negative trial in prevention.
It's like a magical drug.
When you see the differences in the trials, so like going back to having studied medicines and interventions my whole career, and when you look for differences, when you try to do something in medicine, if you see a difference of 5 or 10%, that's good. 15% is considered large as far as an absolute risk reduction. When you see the risk reductions associated with ivermectin and COVID, they are very large magnitude. They're not subtle. They're not small. And this is one of my complaints against the scientific community, is the scientific community keeps dismissing all of the trials, saying that they're poor quality, that they're small, and they keep dismissing them because of the designs. And I have to say that of the many arguments I have against them, one is as follows, is that when you have a flaw in the design of a trial or in the conduct of a trial, it can lead to maybe errors in measuring the differences of a medicine. But when they're that large and repeated, it's not generally the conduct of the trial. And the thing is it's different countries, different centers all around the world, all reporting the same thing. It's very hard to reproduce that consistency in trials from different places, different sizes, different designs, the randomized controlled trials, the observational controlled trials. But I have to tell you, it's very frustrating. The scientific community dismisses it all. They say, give me a large, what they say, proper trial. They want some 3,000 person trial that's done by a pharmaceutical company, that's pristine. They have all the patient data. And so it's very frustrating to try to convince them that the current evidence base is beyond compelling. It's convincing. You just need to look at it and think about it carefully.
Yeah. Because yeah, the thing is, it's a safe drug. It's been used
Yes.
for many years. It's approved by it's on the list of the WHO, like one of the necessary drugs. It's easy to get. The thing is, I've looked at the papers as well. There's some evidence that it's beneficial in the prevention. There's some evidence it prevents mortality. There is some evidence, or at least if you look at the mechanism of action of the drug, it has a very like high potential to be imported for treatment of long haulers, for example. And still, I don't get it as well. Why?
So your argument is the same one that we've been making, is that everything I do as a medical doctor is a risk benefit analysis. Anytime I have a patient before me, I try to help them without hurting them. And in the case of ivermectin, when you have so much, I say convincing, others might say compelling, when you have so much data showing these large benefits, like you mentioned. So I talked about the prevention. If you look at the outpatient trials and the hospitalized trials, you're seeing repeated trials showing large reductions in mortality. There's no other drug that we have in COVID that does that, large reductions in mortality. And then you're even seeing reductions in the need for hospitalization. And most convincing is, as of right now, of the approximately 13 or 14 trials that measured viral clearance, 11 of the 14 show large, statistically significant reductions in the time to viral clearance. We know it's acting as an antiviral, and it removes the virus. It has implications for transmission and for prevention of need for hospitalization. It rids you of the virus much quicker than anything else. And so, and that data, that's another part that I have that I argue against the scientific community. When you're measuring PCR, presence of virus, that's not a subjective outcome that some investigator can maybe misinterpret. That's an objective outcome that's measured from a swab. Why one group would suddenly disappear the virus so much? If that's a placebo effect, I find that highly unlikely that a placebo would rid you of the virus, on a swab. So going back to your question, the data is so compelling. And when you think about the risks and the safety record of ivermectin, if you look at the safety record of ivermectin throughout its history, it's one of the world's safest drugs. It's low cost. It's widely available. So now we're going to get to the difficult question, which is the first one you brought up. Why is no one talking about it, and why is it not being adopted?
Yeah. Why?
Well, let me start with, I'm going to start positively, which is it is being adopted. We have a long list, a growing list of countries just in the last month or two that have adopted ivermectin based, in my opinion, on the very same rationale that you just talked about, Mais, right? Which is the evidence is very, very, let's say, compelling. I'll be nice. It's compelling, and its safety is unparalleled. Why not just try it? And I would also argue you could do very good observational trials. You can give it to groups of people and then see how they do compared to the ones before. Now, we agree it's not prospective, randomized, but it's still compelling. You can do good observational trials. And we've been doing that throughout history of medicine. So I don't know why we threw out observational trials, but for some reason in the pandemic, everybody seems to only want to listen to randomized controlled trials. But right now, the growing number of countries, so look at the European Union, right? In the last month and a half, Slovakia, Macedonia, Bulgaria made it over the counter. People can go to pharmacies now and buy it. And in Slovakia, they have a lot of hospitalizations, many sick people, and they're starting to use it. And the doctors are saying that they're seeing it work. In the Czech Republic as well, doctors are saying in the hospitals that are using it that they're seeing it work. Now, the Czech Republic, hasn't fully adopted it yet, but it looks like that's going to happen. So that's just in one corner of the European Union. If you look at Central America and South America, many countries are adopting. South Africa, Zimbabwe. Zimbabwe did a massive importation. They elected to do one a few weeks ago. And then some of the most compelling data for us is what's happening in Mexico City. At the end of December, Mexico City, at 250 testing locations in the Mexico City metropolitan area, they adopted what we have been sort of praying for, which is a test and treat strategy. Anyone who shows up with symptoms gets tested, they wait for the results. It's a rapid test. And if it's positive, you treat them. And if you look, ever since they announced that, and ever since they started that, a few weeks later, there was a peak in hospitalizations, a peak in deaths, and very, very rapid decreases afterwards. And it's continuing to this day. And so Mexico City has truly compelling data. And so my answer is it's being adopted in many places, but it's not being adopted in many others.
Yeah, absolutely. I mean, on that note, actually, even in the UK, I mean, last year I was surprised because I haven't heard any of the doctors here in the UK prescribing ivermectin, but recently, I think it's since January, group of doctors, they've been studying, all these clinical trials related to ivermectin, and they put the case to Matt Hancock, but we haven't heard anything yet, whether, it's going to be approved or whether they're going to look into it. But the thing is here, if we talk about the side effect, because with high doses, it might go into the brain, it might cause neurological side effects. So how high are we talking here? The maximum dose, let's say, for treating COVID, but without causing any, serious side effects.
I see a lot of people writing about concerns, but let me say a couple of things about that. So number one, it's known as an extremely safe drug. We have, over the decades it's been given, there have been studies in healthy volunteers where they took 10 and even higher times the doses of normal with no side effects. In certain diseases, so there's some case reports in cancer where they gave very high doses for periods of months with no side effects. Yeah. And so it has a very high therapeutic index, right? So to get toxic from it is really difficult. There's been many case reports of overdoses where patients did okay. So it's not the case that if you take too much, it crosses the blood-brain barrier. It's in cases where the blood-brain barrier may be impaired, you might have neurological effects. However, it's extremely and exceedingly rare. There is, just last week, one of the top toxicologists in the world completed a historic review of all of the safety data. And it was just put on a preprint server, but he's a very, very well-known toxicologist from France. And when you look at that report, he basically says that severe events are extremely rare. So it's considered to be very safe. And so the doses used in these trials, although they have a range, I see clinical effectiveness at standard dosing. Even single doses have had clinical effects, but there does seem to be a dose-response relationship in terms of viral clearance. So the more doses you give and the higher doses you give, you seem to reduce the time to viral clearance more. So there is a dose response, but it doesn't mean you need very high doses. So that's why we favor, for early outpatient, we say 2 doses. If you're still not well, you can take up to 5 doses. In the hospital, we say take 5 doses, daily doses 5, but they're standard traditional doses. And so, the trials have not shown any adverse effects from even in this range of doses. And the more recent trials that have come out are using higher doses, and they have not shown adverse effects. There was just a trial last week where they used 5 days, and I can't remember if it was 0.3 or 0.4 mics, but it was quite a high dose, and there was no differences.
Yeah, I'm not doubting, your findings at all. It's just I'm trying to cover what's going in people's mind.
Absolutely,
are sorts of questions people keep asking, and let's talk about the long COVID.
Yeah.
Have you done yourself, like a trial in which you looked at the effect of ivermectin
Right.
on
So
as an
no, where I am now, I don't have the capacity to do a clinical trial. I'm working for my organization. I'm not within a hospital setting right now, but I am treating a lot of patients. I still have a lot of people coming to me. I've treated a lot of people in my network. And I'll say this. So I just gave a webinar a week ago, and afterwards I can give you the link to the webinar because I gave it as for my organization. But I
okay.
went over the data on long COVID. We don't have a ton of data on it, but it's really good data. I mean, encouraging data. So there's a doctor from Peru, Dr. Aguirre Chang, and he's been reporting on
Mm,
increasing numbers of case series of patients who have weeks and weeks of symptoms. And then after they start ivermectin, they feel much better. Myself and my colleagues, I've been collecting anecdotes. Now, they're not a trial, but they're anecdotes. And the reason why I think the anecdotes are important in long COVID is because patients can serve as their own control group. For instance, if you have symptoms for 6 weeks, and in some of these cases, 2 to 3 months, every day you feel terrible in a
mhm.
whole constellation of symptoms, and then you start ivermectin, and within 2 or 3 days, many of the symptoms are gone. I
Yeah.
find that very convincing. Now, either the ivermectin is very effective or it's a very powerful placebo. Um, to the patients, I don't think they care. They just want to feel better. But we're finding
Absolutely.
these really dramatic effects.
And does this applicable to all like symptoms, for example, because most like frequent symptoms at the moment are like the loss of taste and smell, also the fatigue. So did you notice, like
So
ivermectin particularly help with these?
I don't have the data to parse that out, but Dr. Aguirre Chang has commented on it, and I do address that in the webinar. He says that the more responsive the symptoms that respond the most are tachycardia, dizziness, sort of that brain fog that people talk about, that poor concentration. What else do they talk about? Fevers and cough. That seems to do the best with ivermectin. The fatigue and the myalgias, like if you get
Mhm.
like soreness and stiffness, those patients seem to be a little bit harder to treat. But again, this is secondhand from Dr. Aguirre Chang. I haven't been able to collect that data to really see.
Yeah, yeah. And is there a particular, drug we have to be careful when we use with ivermectin, or is there any particular drug which works better with ivermectin? So like both
Yeah.
sides.
So the second question, we don't know really what the synergy of ivermectin and other drugs. I mean, in the hospital, we've been using combination therapy. So we add ivermectin onto our regimen that we use already. In most places in the world, in the hospitalized patient, they're just adding the ivermectin. As far as interactions, important drug interactions, they are few. The big ones are for transplant patients. So there's a number of transplant medicines which ivermectin might lower or increase the therapeutic level of, and so they
Mhm.
should be monitored. And then another one is Coumadin or warfarin, the blood thinner.
Yes.
Sometimes there's comedian interest. So you just really need to monitor these other substances. And then the other drug interactions usually just raise the level of ivermectin or lower it in the blood. And I don't think that they're very important, and I don't think they mitigate the efficacy. But you can look up the drug interactions. But again, the important ones are the ones that I talked about.
Yeah, absolutely. And I know you included in also in your protocol, like you include other medications with which are like really safe and available, but they have a huge impact on the prognosis of the disease.
Yeah.
So, for example, let's just briefly like mention vitamin D, vitamin C, because some people they still doubting, the role of vitamin C, because I know you use high doses of IV vitamin C as well.
Well,
So
that's in the hospital. For the very sick, we use high doses. Yes.
yes, 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 absolutely. So could you like comment briefly on, like let's say vitamin C, vitamin D,
Yeah.
and zinc?
So
Uh,
vitamin D is just it's just plain common sense, good medicine. You want to optimize the patients for when they get ill. We know that the evidence for vitamin D It's repeatable. Those who take vitamin D supplements do better. Now, is it because they're healthier or because they take the vitamin D? When you really look at all the trials, it looks like it really is the vitamin D, because the vitamin D deficiency alone portends a poorer prognosis. So it just makes good sense and rationale. And if you look at the preponderance of the data, vitamin D is indicated for sure. And the sad part is that the governments are even reluctant to recommend vitamin D. We know that our national government, the FDA, has data going back decades showing large proportions of the US population is vitamin D deficient, in particular minority populations. And yet they don't even recommend vitamin D because they're waiting for the perfect evidence. It's extremely safe. It's
same in the UK.
Safe. And so we know, and we have more and more trials showing that people who started taking vitamin D do better in COVID. And then there are even a couple of trials showing that if you give vitamin D to the patients once they're sick, they do better. It's a little harder to use vitamin D as a therapeutic than it is as a protective, but so we say to supplement or at least avoid deficiency. Vitamin C and zinc have decades of literature around viral illnesses. And when you look at them and you really look at those who take it daily and at good doses, not the lowest doses, you generally find better outcomes. And so there is supportive data for vitamin C and zinc as an outpatient. Melatonin actually has an increasing amount of evidence as an anti-inflammatory and antiviral. And so we just have some very safe and supportive evidence behind those. If you're asking about intravenous vitamin C, that's a challenging topic because there's a lot of misunderstandings of vitamin C. Some of the research that I've done, and this is why Paul Marek and myself are very close, is my research uncovered the fact that intravenous vitamin C in septic shock, let's just talk about septic shock because that's really where we first started to learn it, is extremely time sensitive, meaning if you don't give it within about 9 or 10 hours of arrival to the hospital in septic shock, from the time you hit the emergency room doors, if you don't get it within the first 9, 10, 11 hours, it has no impact on outcome, zero. Wow. But if you give it early, within the first 3 to 6 hours, almost nobody dies. And I have a trial, a large database, which shows this really, really tightly. The problem with intravenous vitamin C trials in sepsis is they're all negative. But if you look at every one of those trials, the vast majority, if not all of them, were treated well into their illness, 12, 14, 18, 24 hours into their illness. And so we know that you can't save someone that long into the illness. So we know that early is important. The other thing that we're learning is that, and this is an interesting, we just discovered this in the past, I'd say 6 months, is that in cases where you don't give it early, what we think now is what happens if you don't give it early is the lower doses don't work. But if you give very high doses, even late in the disease, there are impacts on that. And we have growing clinical experience. So we're doing right now, we've been seeing really dramatic responses. We do what's called mega dosing. So we do for severe lung injury, critically ill patients in the ICU. My colleague, Dr. Varone in the FLCCC, he does 25 grams twice a day. So 50 grams a day of IV vitamin C. And he's showing dramatic responses in the lung injury, inflammatory markers, and responses of the patients. But again, we need more data on that. But that's what we believe. It's not only has to be given early. Low doses work if you give it early. They don't work if you give it late. If you give it late, you have to give high doses. And it's going to take us a good 20 years to teach the world that. But hopefully I have 20 years left in me.
Okay, thank you so much. I'm conscious of your time. So just like a final word for, in terms of like the end of the pandemic, now we have, like the protocol you use. We know how pretty much, the virus works. We have a good understanding of the how the immune response, or the immune system react to the virus. We have the vaccines. People are taking protective measures at the moment, preventative measures. So with all this, do you see an end to the pandemic very soon, or are we going to be in the same scenario next autumn?
Yeah, I'm hopeful. I do think a lot of things have to go right in order
Yeah.
for the pandemic to end. You really need a few things to be true. So number one, you need these vaccines to hold up. They have to be over time proven safe. They have to be proven effective over the long term. And those are big question marks. They appear to be working well now,
Yeah.
but we don't know what it's going to be like over the long term with the variant. But if that goes well, that will go well, and that will be important. I don't know what it's like in the UK, but in the US, we have huge parts of the population that will not get vaccinated. There's a lot of vaccine hesitancy. So we know the vaccine is not going to be the only answer here. The other thing that I think is going to be important is the faster that the world recognizes that ivermectin is an important second tool in combating and it's really a bridge to the vaccination, and it's a safety net for if the world deployed ivermectin to the extent it deployed vaccines concomitantly and together, you would have dramatic differences in the pandemic. And then obviously there's herd immunity. And so I do hope that if we're really aggressive and hit everything that we can at it, you will see such low numbers that it can be controlled as it has in some countries, right? But without lockdowns and without all that. But I really think the ivermectin and the vaccines have to work together.
Yeah, I'm optimistic as well. So are you going to try again to approach, let's say, FDA, for example, to convince them with the protocol so it can be
they
part of the
no.
guidelines?
So what is happening is the following. No, we're not interested, or we don't find it's not profitable to talk to the FDA. They're not listening. They are waiting for some large magical trial to appear. And I know there are some that are ongoing. There's one called the Together trial, and there's another trial that's being planned. So I don't know, months to maybe a year down the road, when those big trials come out, maybe they'll pay attention. But for right now, they're not. Here's what is going on, though, is contrary to the FDA and the NIH, the World Health Organization is willing to look at small trials. They're willing to look at preprint trials. They're willing to look at meta-analyses of randomized controlled trials. So I'm sure you know this, but the highest form of medical evidence is not a single randomized controlled trial. It's a meta-analysis of randomized controlled trials. And right now, the WHO, they have a team that's looking at only the ivermectin randomized controlled trials, and they're actively reviewing it now. In about 10 days, they're going to get the last of the data. And at that time, they're going to have data on, I might be off on the number a little bit, about 27 to 29 randomized controlled trials with somewhere around 4,000 to 4,500 patients in that meta-analysis. That is a very large body of evidence. And then they're going to finish their review and they're going to come to a decision. So I don't care about the FDA. I don't care about the NIH. I think the world leader is the WHO. I think they're being the most reasonable. I think they're giving the data a close look. And my only hopes is that they come up with just at least a cautious recommendation. The data is so compelling and it's so safe. I really think that they should guide the world and say, use this pending further data. The risk-benefit ratio tells you to use it. I'm sorry, it tells you to use it.
Yeah, let's hope so.
I hope so.
Thank you so much. Thank you so much for your time. It was a pleasure having you. And hopefully in the future, we could talk again once the WHO makes the right decision.
Sounds good. Thanks for having me. Nice to talk to you.